So this is now going to be all by web?
Yeah, the next two speakers.
Okay.
All right, so we have two speakers with this next section that we have called Designing a Systematic Investigation of MRT Techniques, and we've reversed the order of the speakers from what you may have in your program. So we're going to first hear from Doug Turnbull, who's Professor of Neurology, University of Newcastle upon Tyne, and leads their mitochondrial research group. So Dr. Turnbull, are you with us?
Yes, I am, yes.
Great, thank you for joining us, and you've got the floor.
Okay, so I think I should just state a little bit, I've been listening for the last hour and a half, and just state a little bit about what I do and what the situation is in the UK. So I'm a clinical neurologist that looks after a relatively large number of patients with mitochondrial disease. The situation in the UK is very different from the US. We have obviously a National Health Service which allows a highly specialized service in mitochondrial disease. So I'm the lead of that service, and we provide care for patients from all over the UK. And it gives an example that we see over 600 patients with mitochondrial disease in Newcastle from all over the UK. Having said that, of course, it's only about 300 miles from us to anywhere else in the UK, so it's not got the problems that you have in the US in terms of distance. The other thing I should just make clear is that our work is heavily supported by the Wellcome Trust. I'm involved with Professor Mary Herbert with obviously the IVF approaches, and have been actively involved in this research really from its inception back in 2000. The other thing, just as a kind of slight warning here, is that my phone has a habit of cutting out, so if I am lost, I'll ring back, so just to let people know. So what I was asked to do was say a little bit about, and I've listened to the previous discussions, about potential approaches to how we might be approaching this in the UK, and also what guidance I might be able to give to you in the US. So clearly we work under very different systems. I think John Gerhardt's already, or people have already said that we work with the HFEA, which is a regulatory authority which covers the whole of the UK, and all IVF clinics and techniques in the UK. I think what I've learned over the last 5 years since we've been campaigning to get this so that the law's been passed through our House of Parliament is that compared to previous IVF techniques, there's been an awful lot more scrutiny of mitochondrial replacement therapy than any of the other techniques that have been that are currently in clinical use. And I think that's a very important thing for the committee to remember, is that this has been looked at far more extensively than IVF itself, certainly more extensively than PGD, and certainly more extensively than ICSI and blastocyst transfer. So I think when we talk about preclinical evidence, the preclinical evidence and the reviews that have certainly been done in the UK, which again John Gerhardt is I think rightly said, have been rigorous and timely, have involved a collection of both published and confidential evidence from a number of centres and have come to their conclusions. So I think there is quite a lot of preclinical information out there, and that was certainly enough for our HFEA to think that we should be moving forward towards the more clinical aspects of this. The other aspect that I think I've become aware of is if there are abnormalities with certain IVF techniques, these are often very subtle. And I think, again, that has been referred to, is that when we consider the potential epigenetic effects of things like of IVF or ICSI, that we're talking about hundreds or thousands of patients or children that are being assessed. So I think it's not unreasonable to say that major abnormalities will be picked up relatively straightforwardly. Whereas if we are talking about some of the subtle changes in epigenetics, then this is going to be a much larger study and will only be done by combining data from several centres and potentially several countries. The next bit, and I've only listened this morning, so I haven't had a chance to listen to yesterday's discussion. But in the UK, the policy on this, and in fact some of the decisions on this, have also very much reflected patient involvement. And it'll come on to when I've only got 4 slides, and I was going to cover something around a long-term follow-up of children, where we've consulted families extensively. And I think it's very important, or it's also, no, it is very important in the UK that we consult widely with the families and involve the families in many of the discussions that we are having around even not only just the ethics, but also in safety and some of the science and some of the risks that they perceive and some of the desires that they have in terms of especially those families who've had multiply affected offspring. So let me just give you a brief summary of what's happened in the UK. You will know that we've been researching on this for a large number of years. In the UK, you will also be aware that, as I've said, that the HCFA regulates all IVF techniques. It is a body which is regulated by Parliament. Parliament passes the authority to the HCFA. As you will know, that both houses of Parliament voted unanimously, not unanimously, you voted overwhelmingly to support these techniques. And that law went into law on the 3rd of March this year. The situation is that the techniques are not going to be allowed in the UK until the 1st of October. And the techniques will be dependent upon a licensing by the HFEA. The licensing by the HFEA will include some of the issues that you've been talking about, which will definitely be the competence of people, of the clinics that are performing their techniques, as well as having adequate clinical services in both counselling and following up of children. So the situation in the UK is very different from what's actually happening in the US. So perhaps I can just go on to the next slide. So, and I've just responded to some of the issues that Rebecca has put in the slide, put in the questions. So, how to determine the efficacy? I think we have in the UK considered the risks in great detail. I think one has to balance the risks of the transmission of a mitochondrial DNA defects with the risks of the preclinical tests that have already been done and some of the published tests on human eggs and embryos. There is a certain reluctance in the UK to consider, and I think this is something that we're still trying to work out ourselves, whether or not after mitochondrial replacement therapy we should then be doing, as was suggested, either PGD or amniocentesis or chorionic villus biopsy. I think that very much depends on the preclinical data. If the preclinical data in human embryos suggests that the carryover is going to be minimal, if the preclinical data suggests that there isn't going to be a large amount of epigenetic change, if the preclinical data suggests that you aren't going to have chromosomal abnormalities, I would be slightly worried that any intervention that you do might then be biasing the data under normal circumstances. So I think we have to give this very careful consideration. We would, hopefully, and I'm going to come on to this in terms of the children, we would want to assess any samples from the children for a level of heteroplasmy, and preferably a blood sample, which I think we would believe would be adequate under these circumstances. I think I've addressed in some senses what we'll be looking at in terms of abnormalities, and clearly if there are major abnormalities over and above the normal birth rate of abnormalities that you would get with any sort of normal reproduction or IVF, then we clearly would be looking for those. But I personally believe if there are any epigenetic changes, then these are likely to be subtle, and I think the large numbers of patients will be required. And then the final point is about a control group. I think it's very difficult to think of a control group. I think we know the natural history of mitochondrial disease. We know we've got large families that were already collected, that we're already following up. So I think it is very difficult to think of a control group. The only control group I can think of is PGD, where again PGD might be the technique that some women will choose in the UK, and mitochondrial replacement therapy or mitochondrial donation might be the technique for others. So I don't think I've helped you very much there, because I think there's so much uncertainty under these circumstances. But I think we have to see that major abnormalities we would hopefully detect with relatively small numbers of patients or families. Minor abnormalities, gauged by what else has happened with IVF techniques, we're going to need a large number of patients. Could I go on to the next slide, please?
Dr. Turnbull, you're at about 10 minutes now, so just a
okay,
reminder.
Right. So I just want to just about the how would children be assessed, and I think there's something you're going to discuss. So if we could perhaps go on to the next slide. So we've discussed this extensively in the UK. We have excellent antenatal and postnatal care in the UK, which we believe would detect major abnormalities. So in addition to that, at the moment, and I think this is something that we're clearly reviewing, is that we would encourage patients to consent to providing a sample of blood, and we would ask for a formal review by a neurologist or a experienced pediatrician at our centre. I think, again, it's much easier in the UK because the distance involved are much smaller, and therefore I think it is reasonable that we would follow up and we would keep a database of any children that have been born via these techniques. Okay?
Okay, excellent. Thank you very much. You'll be able to stay on the line for questions and after our next speaker?
I will indeed.
Thank you. Thank you so much. All right, next speaker then is